Welcome to the debate. Our motion today is COVID-19 has killed quality improvement. For the motion, we have Christina Kraus. Christina is the Chief Executive Officer of the British Columbia Patient Safety and Quality Council of Canada. Joining Christina for the motion is Greta McLachlan, and Greta is a General Surgical Registrar Trainee, Leadership Fellow at Cleveland Clinic London, and co-founder of the Women's Speakers in Healthcare. Okay, welcome to the team for the motion. Against the motion, we have Amar Shah. Amar is Chief Quality Officer at East London NHS Foundation Trust. Joining Amar is Bevan Elliott. Bevan is the Community Health Implementation Lead for NHS England. And we will be hearing our 4 debaters shortly. We are also joined by our 3 adjudicators. Ellen Kaustrup is the Head of Office Quality and Safety from the municipality of Aarhus, Denmark. Christian Westergaard is a medical doctor working with the Danish Society for Patient Safety. And finally, our 3rd adjudicator is Tobias Brigert-Damsk, and Tobias is a healthcare specialist, medtech entrepreneur, and expert patient. So let's describe what's going to happen with our debate this morning. Shortly, we're going to have a pre-vote. Okay, and it means that all of us that are joining us directly and not on the live stream will be able to pre-vote before the debate as to whether they agree or disagree with the motion. We will then move to round 1. And in round 1, each speaker will get 2 minutes to put their argument. And how this will work is we'll take the first speaker for the motion, the first speaker against the motion, the second speaker for the motion, and the second speaker against the motion. Round 2 is where those of us who are joining us on the session will get their input. And what we want you to do is to ask questions of our debaters, and we will put that to them directly. So we want you to be thinking now about questions that you want to ask to our debaters to help you make up your mind as to whether COVID-19 has killed quality improvement. And what we want you to do is to put your questions in the conversation box. So please start doing that now, and we will feed those questions directly to our debaters. And then the final part of the debate, round 3, is that we will give each speaker 1 minute to sum up their arguments. And again, we will do that in the order: first speaker for the motion, first speaker against the motion, second speaker for the motion, second speaker against the motion. What we will do then is we will take another vote. And what we want to do is to see whether your views have been swayed by the debate. But we're going to take the poll then, but we're not going to show it to you then. What we're going to do is we're going to ask our 3 expert adjudicators to give us their views. And we're going to ask the adjudicators what they thought about the team for the motion, what they thought about the team against the motion, and then we're going to ask them to give us their adjudicators' verdict. And finally, we will reveal the people's choice, what your vote has been. So in a sense, what we're going to do is we're going to take 2 sets of outcomes from this debate. We're going to hear from the adjudicators, and then we will hear from you, the people. So let's get going. What I'd like us to do now is to take the first vote. So for those of you that are taking part in the session, okay, you will be able to see the vote now on your screen. And we want you to basically say the motion, COVID-19 has killed quality improvement. Okay, I want you to say I agree or I disagree and submit. For the many of you, the hundreds of you that are joining us on live stream, it's fantastic you're with us today, but unfortunately you can't vote and ask questions. But you can still have your own views about this, and hopefully they'll change. So just give you a couple more seconds to vote. So let's see our starting poll. Okay. So what we're seeing here is, to start with, only 20.9 of us are agreeing, and around about 79% are disagreeing. So what we're going to do is we're going to take that again. So most of you don't believe that COVID-19 has killed quality improvement, but we'll take that a vote again at the end, and we'll see whether your views have changed. So buckle your seatbelts and let's get into this fantastic debate. So before I introduce our debaters for round one, can I just call on our adjudicators to turn off your cameras and your audio so that we can now focus on our debaters. And can we get rid of the slides? Fantastic. So I would like to, first of all, to call upon our first speaker for the motion, Christina Kraus, and can we show the clock as well? Okay, Christina, tell us why COVID-19 has killed quality improvement. Your 2 minutes start now.
Great, thanks, Helen. So the other side will argue that QI is alive and well, that we've become more agile, innovative, and we're seeing fantastic changes resulting from COVID. But I want to start by asking you to reflect on what we mean by quality as part of the concept of quality improvement. The quality that I know and knew pre-COVID had multiple dimensions. There was respect, patient-centered, access, effective, equitable, and safe, and all have value. And yet we now have put safety above all of these other dimensions. We've separated our loved ones in long-term care, and we have prison-style visits. These seniors are now starting to show early indications of increased symptoms of depression and unexplained weight loss. These are key quality indicators. And a new paper showed a 20% increase in deaths in the United States over the COVID time period, and only 67% of those were attributed to COVID. The other third is just collateral damage. These unexpected deaths are disproportionately affecting the most vulnerable in our society, and COVID has exposed a dire inequity that we have in our world. And as Dawn said in his plenary earlier this week, there is no quality without equity. So how do we do quality improvement without quality? Well, COVID has certainly resulted in change, but as we all know, not all changes lead to improvement. Improvement has been built on developing and testing changes, but it's also been built on engagement and co-creation with our patients as partners. However, overnight, what we thought was hardwired into our system went out the door. We've moved back to an old school command and control approach, becoming once again the norm. So yes, we've pushed changes quickly, like virtual care overnight, but it isn't co-designed. So we don't have quality improvement, it's dead. We're now living in a world of COVID care, not quality care, and that should worry us all. Thank you.
Whoa, thank you so much. Strong opening there from Christina.
Yeah.
So let's move on now, and I would like to call on the first speaker against the motion. So Amar, your 2 minutes telling us why COVID-19 has not killed quality improvement starts now.
Hello, my name is Amar. I'm a clinician and an improver that works in a healthcare provider, leads improvement across England for mental health, and supports improvement globally with the IHI. So what have I observed in 2020? Has COVID-19 killed quality improvement? Well, first, this is not a debate about whether we've seen high quality. This is a debate about quality improvement. And what is quality improvement? Well, quality improvement is a systematic approach to solving a complex problem, coalescing around a shared purpose, involving those closest to the issue in developing and testing ideas to discover solutions that can make a difference. And what have we seen during COVID? Well, we've seen the healthcare world face a challenge of immense complexity, where we haven't even genuinely understood the problem and certainly haven't had all the answers. So we've faced a truly complex issue. In that context, we've seen the healthcare workforce around the world rise to the challenge with a powerful shared purpose of saving lives, protecting the vulnerable, and serving the community. We've seen teams across the healthcare system make changes rapidly, trying out ideas and adapting them as they learn about what works and what doesn't. And we've seen leadership that is really focused on providing an environment where teams feel able to make decisions, try out new ideas, and improve care. And what is that, if not the true essence of quality improvement? Teams being liberated to make decisions, try out new ideas, be innovative, and keep adapting as they learn. So rather than kill quality improvement, COVID-19 has liberated quality improvement. Our challenge now is to strip away the bureaucracy and language that can stifle QI sometimes and embed this powerful approach to change whilst helping people see that QI can help us even when not at times of crisis, how measurement doesn't have to be burdensome, and how the rigor of QI is more effective than the just do it approach. QI is not just alive and well, it's flourished during COVID-19.
Whoa. Thank you, Amar. Again, another very strong start. So let's carry on with our debate now, and let's hear more of the argument as to why COVID-19 has killed quality improvement. So I'd like to call on Greta as our second speaker for the motion. And Greta, your 2 minutes starts now.
Good morning. Thank you very much for having me. And I'm here partly to represent the trainee voice in this. And Amar, I'm going to start off just by coming back at you with something that you said about the healthcare workforce has risen to the challenge. I would agree with you on this. However, what is the cost at which we have risen to this challenge? Prior to the pandemic, burnout in clinicians was as high as 55% in some surveys and was costing the US healthcare system $4.6 billion a year. We know that during COVID, we've seen more PTSD symptoms reported in caregivers, as well as increased rates of depression and anxiety. If we look at the recent UK GMC national survey, which had over 28,000 respondents of just trainees, 40% of trainees are sharing and showing that they have higher workloads than pre-pandemic levels. 25% of these trainees are feeling burnt out because of their work, and 49% feel worn out at the end of the working day. We know that burnout is associated with a loss of empathy, impaired job performance, and increased medical mistakes. So where do we have time for QI? I agree that QI needs to have a systematic approach to solve a problem, but when we're just trying to keep our heads above water and trying not to become burnt out, phased, cynical clinicians, we quite simply don't have the time for QI. Put into that the fact that a lot of QI staff are being redeployed, as quite a few of them have clinical backgrounds. There simply isn't the staff to be able to perform QI to the level that we would expect it pre-pandemic. You've also said that QI has been liberated, but where's the safety element of that? Agility and fastness can sometimes come with a cost of safety for our patients.
Thank you, Greta. This is shaping up, I think, to be quite a battle. So let's go to our final opening speech from Bevan. So Bevan, I'd like to call on you as the second speaker against the motion. Bevan, your 2 minutes on against the motion, COVID-19 has killed quality improvement, start now.
Thank you very much. I do hope that wasn't any technical interference from our opponents there. So wholeheartedly, I disagree with this, wholeheartedly. And in fact, I feel like I need to build further on the points that Amar mentioned earlier, because I really do think that during this time of COVID, there have been certain areas which we have seen change like no other. And for me, one of those is about the barriers to quality improvement. One of the challenges with quality improvement is being able to be able to feel as though you're collaboratively moving towards a shared purpose and a shared goal. And often there are barriers there that are often outside of your control and you have very little influence on. But here in England, we have seen barriers literally shut down at a level where we're able to see national scale impact. We were able to see, for example, patients who were in hospitals for long periods of time And when it came to actually discharging them, there were challenges and there were delays in that. Through COVID, we were able to see patients who have been in hospital for really, really long periods of time actually able to go home or to a usual place of residence with the packages of care put in place that stopped the delays and stopped causing the issues in terms of hospitalization. We've seen mobile working and data at a level that we never saw before, and the opportunities open up for technologies in this place. And in fact, I'd even like to go against our colleagues here debating today and talk about health equalities, because I think actually what COVID has done is really shine the light on how health inequalities for our older generation, for our BAME communities, and for other disadvantaged communities has really had an impact. And I think it's not just COVID now that we're looking at health inequalities, but it's reminded people that health inequalities exist across all conditions.
Yeah, great. Again, I think, bringing some brilliant new aspects into our conversation, really important there. So thank you, Bevan. So, audience, that is the end of round one, where we've heard the opening statements from our 4 debaters. What we're now going to do is move into round 2, which is our opportunity to ask them any questions that you want to ask our debaters that will help you potentially to change your mind from your current. So what I'd love you to do is to put any questions, those of you that are taking part in the actual session, is to put any questions that you've got into the conversation box. So what would you like to ask the speakers that will help you change your mind? So the question I've got to start with is, I want to ask each of our speakers, okay, what question would you like to ask the opposition? Okay, so in terms of things they're saying that you don't agree with. So what I'm going to do, each of you, I'm going to go around and I'm going to give each of you the opportunity to ask a killer question, okay, to the opposition, and let's hear the reply from the opposition. So Christina, I'm going to start with you, if that's okay. Okay. Yeah. So what question would you like to ask Amar and Bevan?
So I think, Amar, you said this debate isn't about quality, it's about the process of quality improvement. And I find that a little bit confusing, because the goal of quality improvement is to improve quality. And right now in our system, we are making improvements related to COVID. I don't argue that. And we've redesigned the system in response to COVID, but there are a vast number of areas where we cannot focus on quality improvement from a true systemic balanced approach that is causing new quality issues, because we cannot do QI in those areas. And I think of our vulnerable seniors, I think of Bevan's point around the inequalities, and I'm going to challenge you around how can quality not be part of this debate when it's about quality improvement.
Okay, Amar, answer that question, if you will.
So simply using quality improvement doesn't automatically mean that we're going to improve quality, right? Quality improvement isn't always successful. This debate is really, have we seen the application of quality improvement? And yes, we have, but that doesn't mean that we've solved all of our problems. In fact, it would almost be impossible to assume that just simply using quality improvement means that we're going to solve all of our quality and safety issues.
Okay, thank you, Amar. Without even drawing breath, okay, what question would you like to ask back to your opposition?
How would you explain to people across the healthcare world who've been involved in trying out new ideas to help us figure a way through this immense challenge, that they haven't been applying quality improvement, when all they've been doing this year has been testing the bounds of new knowledge, trying out new ideas, and making changes that have cumulatively led to us getting to where we are today?
I think it depends where you sit in the system. I think there are a number of individuals who are making changes and are engaged in those changes, but there is an overwhelming number who are passively being recipients on being told what to do in response. And the number one thing I hear from people working in the system is they feel like we've regressed back to a command and control. They've lost their autonomy. They're experiencing the burnout, as Greta mentioned. And that slide back into that command and control, which at the beginning of the pandemic likely was necessary, but we are seeing old patterns that we know get in the way of quality improvement.
Thank you. We're being very nice and polite to each other here. That's surprising. Okay, Greta, what question would you like to ask your opponents?
I think I'll go with asking Devon, seeing as Christina and Amar have been chatting a little bit. Devon, you mentioned obviously about a shared purpose and a shared goal. Obviously, we've been fighting COVID, but haven't all of the QI projects or improvements all been COVID related? As Christina said, this is COVID care at the minute, not quality care.
I would disagree with that. I mean, if you use the example that I mentioned about remote and video technologies, in fact, in the UK, this has been something that's been on the radar for some time, and many providers were already making the steps to move to being able to see patients in a remote and video fashion. What COVID has pretty much done is accelerated that because of the need to keep socially distant and other factors, but it's just enabled another way to be able to keep contact with people. We do need to obviously be careful of the inequalities that I mentioned, but it is again another solution that was thought about long before COVID was on the scene.
Okay, we're still being extremely polite.
Well, in that case, if you want slightly less polite, then I'll come back at Devon and say, it's interesting that you say that, because actually, if we look at things outside COVID, and I agree, the virtual technology has definitely increased and improved and was put out in the long-term plan, and we're now there. However, if we look at the UK just in general, people will now be waiting for treatment. It's estimated there'll be 10 million people waiting for treatment in the UK by the end of 2020. And if you look at research from cancer research, they're saying that 3 million people did not receive their screening tests in the 18 weeks after March 23rd lockdown. So again, if this is quality improvement, it's only improving in certain areas. There are definitely areas, and it going more into that health inequalities, that are definitely being forgotten or put at the wayside because our single purpose is COVID at present.
Yeah. Go on then, Devon. So you can ask your question back. You can stay on the same topic, or you can take it wherever you want. What do you want to ask your opponents?
Well, I was going to perhaps take my question from a slightly different perspective, because it was actually related to this topic. So I was going to say, what would our opponents say to my 82-year-old grandmother, who has actually, through what we would have said COVID times, has actually been able to have more appointments with her clinician than she did in the last 6 months than she did in the last year. What would you say to my grandmother in terms of her ability to be able to have contact with her caregivers?
Shall I take this one?
Sure.
I love that you're using an emotional story, Devon. Very nice. I think your grandmother's obviously had a good example, and I think it's difficult when n equals 1 to then posit against that. But I think we also know, as Christina mentioned, there are lots of people in care homes who have been completely shut off from the world and shut off from their loved ones. And yes, whilst we've been protecting them from COVID, have we maybe removed some of their humanity and some of their soul, in that the only joy that they may have had is visits with their grandson, visits with their daughter, and actually we've taken that away from them. And if one of the proponents of QI is patient participation and collaboration, then we haven't had that discussion with our patients. We've simply told them that to protect them from COVID, we are not going to allow visitors in to see them. Same in hospitals. Patients are dying without being able to hold their loved ones' hands because we're protecting them, whereas we're not giving them that choice. And that to me seems fundamentally poor quality, because actually, if we gave them the choice, would they sort of say, actually, I'd rather die from COVID and have a hug from my granddaughter versus not be able to see them for 6 months and maybe come out the other side, but be more depressed, be more anxious, and a lot more lonely.
I mean, it's very to obviously bring some of the hardest case scenarios and try and use that as one to be a reply example. But I think that with your comments, are you able to also see that, you know, with every country across the world having different rules and regulations on how people can still keep in contact with their services, how you can still see your elderly loved ones who may be in care homes or in other places. I mean, the challenge was that the rules applied to everyone in terms of being separate, and healthcare has a responsibility to try and keep those relationships, to try and keep those connections with people. And if we've got the technologies there, we should be trying to do that within whatever context and country context that we sit in. So do you not see that in terms of quality improvement and initiatives and ideas, that these things take those initiatives and that idea and that creativity forward? The real challenge is about, and this is quality improvement in general, sustaining these things where they're appropriate.
I agree, and it would be lovely if we can sustain these, but I also think we have to think, as we're at an international conference, we need to think about this from an international perspective. From the Western perspective, then yes, we are able to have these things, but will all countries be able to have that virtual technology? And how has COVID affected those countries that maybe don't have that virtual technology or that ability to FaceTime, or to have these projects instigated overnight? So I think there's a wider angle to this as well.
Thank you. So what we're going to do, we're going to start taking some more questions now. So the question I'm going to give I'm going to give it to Amar first, and actually then to Greta. So both Christina and Bevan, okay, use care homes of examples. First of all, Christina used care homes as an example as to why COVID had killed quality improvement, and then Bevan used exactly the same context to argue why COVID hadn't killed quality improvement. Okay, so Amar and Greta, talk about care homes, okay, and the extent to which what's been happening in care homes has during COVID has killed or not killed quality improvement. So Amar, over to you.
What I'd say is, just because we've seen quality improvement accelerate and progress during COVID does not mean that we have used it as well as we should have done. Actually, if we had properly used quality improvement in our overall approach to this, we would have recognized the balancing factors we should have been paying attention to when we were trying to create acute capacity. And I think that's a flaw. That is from the failure of applying quality improvement where we should have done. But that doesn't mean quality improvement has been killed. It hasn't been killed. It's been present and live and kicking, but it hasn't been used universally and it hasn't been done well everywhere. So I would say we have an opportunity to learn about how to do QI really well by involving people much more deeply in understanding what matters to them, and that driving the improvements we make. And we've seen it in places and we need to learn from that, but we have not seen it universally. Okay.
What do you think of that, Greta?
I think it's interesting that Amar says that, because it sounds like he's arguing for our side. To be honest, I think there are a few points there that we should take on board. And I know that Amar has written in the BMJ about this as well. And I think what he's talking about is that lip service that is paid to QI. And I think actually quite a lot of the QI that has been going on during COVID has been lip service. I don't think we've had the time or the energy to plan properly, even just as simple as your PDSA cycles. I don't think there's been enough planning. It's all just been acting. It's been a very command and control, top-down heavy leadership. We know that a facilitator of good QI is good clinical leadership. And can we all honestly say that we've had good clinical leadership in everywhere that we've been working? Probably not. Which is a sad reality of not just the NHS, but the wider healthcare systems on the whole. And to go back to the care home problem, I agree we were able to get people out of hospital quickly. Isn't that wonderful? Apart from the fact that were we then spreading COVID into these care homes, and that's where we know the majority of the community infection of COVID is coming from. Had we have thought perhaps a little bit more about where these people were going and the homes that they were going into and the number of people that they were effective, would we have actually had fewer infections and been able to control the virus better than we have done? Only time will tell on that.
Okay, thank you. And I'm going to move us on to the next question now. Okay, we're got another audience question now. Okay, which is and what I'm going to do, I think we're going to start this one with Christina and Bevan. Okay, but then you know what I'd say as well. It's a debate, it's an argument. So let's not be so nice to each other. Okay,
we're very British, Helen.
Yeah. Well, let's debate. So far, none of you have mentioned the shift to virtual approaches to care that have been stimulated by COVID. Okay, there's a dichotomy in some of the relationship around virtual care. It's either all good or all bad. Okay, and this suggests just how far we have to go to have healthcare systems that actually embrace quality improvement and are able to personalize care. Okay, so what can we take, from the virtual care example to either make or dispute the motion that that COVID has killed quality improvement? So you start, Christina.
Yeah, I'd be happy to. For me, quality improvement goes well beyond PDSA cycles and having a balanced set of measures. And many in the chat have commented a lot about the lack of balancing measures that we've had so far around COVID. So effective QI, balancing measures and watching what we're not looking at hasn't been happening. But on the virtual care one, which around the world, we saw the shift literally overnight. We've been working on this in British Columbia for years and years with slow progress. And in 1 week, we put it into place. The problem I have with the virtual care strategy is that patients were not part of that design. Quality improvement, COVID killed patient engagement and quality improvement. And for me, that is a fundamental requirement for meaningful quality improvement, patients at the table. So we have a provider-centric virtual approach currently. We have patients whose GP appointments, when you phone for an appointment now, the response is your provider will call you in a week, and they will call you when it's convenient for them, not at a booked time, but at a time that works for them. I had an appointment in the grocery store because I've been waiting for my GP to call me, and it works for her. And that's the new design we are in. We are now just starting to catch up with patients at the table and say, now we need to pause and do that. So when you ask me, what did COVID do for how we're putting these changes in place? It took patients away from the table because, one, we didn't know a way to engage them meaningfully. Many of them don't have the technology or the systems to access. And two, it was designed purely by providers. That to me is not good quality improvement.
And Christina, in a way, you're correct that in those examples,
that's great, Amar. We can
just stop there, Amar. Stop there.
There is no noticeable evidence of quality improvement, but actually, quality improvement was dead before COVID in those settings. People didn't really truly believe in it, if that's their approach to complex problem solving. Whereas what we've been hearing is that the organizations that have really invested over multiple years in helping apply and learn quality improvement, those organizations have reaped the dividend of that now because they've held on to patient involvement deeply throughout this process of navigating complexity. And they've involved people deeply in testing and learning throughout. So you may feel quality improvement has killed, COVID has killed quality improvement in some settings, but actually it was dead even before COVID.
Oh, go on then, Bevan, add to that, because I said you were going to speak on this.
Well, I mean, Amar almost jumped in on the point that I was hoping to jump in on, because I think, if you remember, I said that in certain areas, we've been thinking about technologies and how we can use the virtual space and remote technologies and all other kind of technologies that can benefit healthcare long before COVID was on the scene. And so where you've had where healthcare providers have had that capability to apply quality improvement to how they do the healthcare, then a lot of the patient engagement would have come from before. And there's still, with patient engagement, it's something that happens throughout the longevity of quality improvement. It's not something you just do at one point. And so in the eyes of quality improvement, you would be doing that through continuously and on a cycle. It's not something that would stop. And so, just to, I think, reiterate the point that, you know, often the rationale may feel that it's that COVID is coming and things are being done on knee jerk with absolutely no thought behind it. But, you know, in England, there's a long-term plan where there was already talks about, investing in technologies. We'd already been having these conversations from before. This is not something new. It's just COVID has accelerated it. But as Amar said, not in the true spirit in which we would have wanted to. So has COVID killed QI? Absolutely not, because now will be the time for us to then start to apply those principles hard and proper in the right ways, so we know we can maximize the benefits and be able to get the impact that we're hoping for.
So Christina rebuttal, because we've just heard from Amar and Devon in response to you.
Yeah, no, I think ironically, I agree with Amar. I think QI is dead. And I think part of this, the whole purpose of this debate, if we go to this, the question being asked, did COVID kill quality improvement? If we can agree on what the core requirements are of quality improvement, we are not, in some cases, it's happening. In other places, it's not happening at all. Variation, as we know, is one of the core things that we're supposed to be minimizing the quality improvement. What we have globally is significant variation around whether or not quality improvement has been able to be maintained. It depends on culture. It depends on the size that you're trying to affect. In British Columbia, we have a significant geography. We have a large number of rural, remote areas that it is difficult to engage than if you're in a large city, perhaps like maybe you have in London, Amar, where you know it's different. But the key for me is the things that we value around quality improvement, which does include quality. You can have great methodology that is, doing good methodology for no purpose. To me, that is not quality improvement. It must include the outcome. So the argument that we shouldn't be including quality as part of this debate is sort of mind-boggling to me. We cannot say we are doing effective quality improvement when we are focusing on one dimension of quality at the expense of all others, and focused on one clinical problem at the expense of all others.
Yeah, fantastic. So we're coming to the end of round 2 now. So I've got one question, and I'd like you all to answer it. Okay, and we can be polite this time, and get you all to answer it in 1 or 2 sentences. Okay, and our audience question is, do we want to maintain quality improvement as we know and experience it? And is there a new dialogue emerging? So what's the new dialogue? So let's do that in the order of let's do it in reverse order to your closing statements that you're going to give in a minute. Okay. So Devon, okay, is there a new dialogue emerging about quality improvement?
I think there is, Helen, and the reason why I say that is because just by the nature of quality improvement, it's something that's meant to always continue to be happening. It's not. I think the real challenge before was that quality improvement was often seen as some kind of bolt-on thing, something that we did on top of the day-to-day. When really the crux of quality improvement is that it's at the heart of what we do. It's in, we come into work with a view that we are going to make things better today. We're going to do things better today.
Right. I'm going to stop you there because that's a lot of sentences,
yeah,
but I think you're putting that across very passionately. Yeah, I can hear it. That's great. Greta, okay, 1 or 2 sentences. Is there a new dialogue emerging?
I think there definitely is, and the one thing that I will proffer forward is that actually foundation trainees in the UK are now, during COVID, it is not mandated for them to be doing QI to get their end of year sign off. Now, if that to me isn't a sign that QI has been killed by COVID and that there is needs to be a new way of looking at QI, I'm not sure what is, because the message that we're sending our trainees is that QI isn't important and isn't necessary at this time.
Okay, great, thank you. And Amar.
How can we call ourselves improvers if we don't continually improve the way we improve? We've got to strip away all of the bureaucracy and process that's stifled QI, the language, the barriers that people experience. You can't mandate QI. People have to truly believe it as a better approach to complex problem solving. That's what we need to get to.
Okay, thank you. And finally, Christina, in terms of what's the what's the new dialogue?
Yeah, we without a doubt need a new dialogue, because quality improvement is all about learning. So if we don't learn from this journey, not only around quality overall, but how to do improvement, then we need to, we either need to kill QI or make sure it's dead. So yes, we will go on a new journey and learn from the positives and the negatives that we've seen so far.
Okay. Brilliant. So thank you. I think very strong arguing there in round 2. And we're now going to move into our final round, which is round 3. And what we're going to do is we're going to give each speaker just 1 minute to summarise and to make a plea to all of you as to why you should vote for their side of the motion in the final vote. So we're going to start with Christina. So if we can put the clock up.
Mm-hmm.
Let's wait for it to come. Yep, here it comes. Christina, you have 1 minute, okay? Let's hear your final statement for the motion.
So the motion before us was whether COVID has killed quality improvement. Quality improvement is looking at the system, looking at where the issues in care are, and working to improve them. We have issues that exist in our system that extend well beyond COVID, and we have dropped them. We have left them behind. This command and control response to the crisis that was necessary at the outset still seems to be in place. Depending on where you sit in your organization and the culture you have, you may believe we've lost the impact of QI around recognizing the value of meaningful engagement or not. But for many, we have. We don't have a balanced approach to quality, and every strength overextended is a weakness. If we only focus at one thing right now, we will forget about the complexity in our system, and only mitigating one thing will not increase quality of care. We've got to move on from COVID care back to quality care.
Yeah, fantastic. Well done, Christina. And moving on now swiftly to Amar. Amar, give us your final statement against the motion.
So this debate is about quality improvement. COVID's shown us what we knew before. Some leaders only have command and control in their toolbox. They don't apply systems thinking or use data to inform decision-making. Some health systems have never truly embedded and believed in QI, but the true essence of QI is about letting people solve complex problems through testing and learning. We've seen a scale of change in learning in complex systems we would never have predicted. People have a taste now for the autonomy and the possibilities that improvement can bring. And the real failure would be if we don't learn from 2020 to improve the way we improve. We've seen so many people describe their health systems that have invested in QI over many years, double down on quality improvement and people participation, and really bring that into the way that they've responded to QI and have seen benefits from that.
Yeah, wow. Again, very strong. Thank you, Amar. So let's hear the closing statement from Greta as the second speaker for the motion. Greta, over to you.
Thank you very much. I'm going to try and make 2 points in the next minute. And the first being that the Health Foundation has shown that barriers to QI include high level of patient demand, which we definitely have in COVID, too many demands on NHS agencies, which we've definitely had in COVID, and clinical staff shortages. Again, we've definitely had those in COVID. So I think we can definitely say from that point of view that COVID is killing QI. Now, from a slightly different point of view, I'd like to point out about equality, because John Berwick said we can't have quality without equity. And actually, if we look at the number of papers being authored during COVID, and we look at the male versus female authorship, COVID-related papers have dropped by 16% in relation to their normal output in regards to women. So if we look at 2017 versus now, the authorship of women medical papers on COVID has dropped by 16%.
Okay. Thank you, Greta. And okay, finally, Bevan, our very last closing statement. Over to you.
For me, I think the important message to take away is that QI has learning at the heart, at the center. You're not doing quality improvement if you're not learning as you go. And I think for me that's why it's the time for QI is now. We haven't learned as much as we have learned in the last 6 months in a time that similar time frame I can ever imagine, and we have to use that. And if I could think of 3 things that I would say that would be takeaway messages, is that we need to adopt and adapt the things that have been successful, the things that people feel have worked during this time. And then for the last day, I think we need to abandon things that we know are barriers to quality improvement, barriers to quality as well along the journey. And we need to take staff, patients and public's view along with us.
Yeah, brilliant. Okay, thank you, Bevan. And okay, so our 4 debaters can kind of breathe a sigh of relief because the formal debate process is over, and you did magnificently. So what we're going to do now, moving into the final session of our debate, and we're going to rerun the vote. So can we put the poll up again? What's going to happen? What's going to happen now is that we're going to see the we're going to rerun the poll. So if we could pop the poll on the screen. If everybody could be putting their answers, we're not going to be able to we're not going to see the results of that until after we've heard from our adjudicators. So at this point, what I'd like to do is to ask our debaters, for the moment, we're going to bring you back in a moment, to close off your cameras and your audio, and can we bring our 3 adjudicators onto the screen? Yeah, great. So the 3 of you have been listening intently to our speakers, and what we want you to do now is to tell us how what you thought. So first of all, Christian, will you give us the view of the adjudication panel on the team for the motion? Over to you.
Thank you so much for giving me the opportunity to do this. First off, I would like to say that both teams did tremendously well. We think that the opening statements from Christina and Greta were really strong. That Christina brought these opinions about quality improvement in general, and then Greta backed those up with some statistics and facts, some sort of evidence, if you would like to say that. For me, as a trainee personally, those things that Greta said sounded very, very strongly with me. Now, again, they had a very strong point in the loss of autonomy, both from the care provider side, however, also from the patient-centered view that patients are not co-creating the healthcare anymore. Really asking us, setting the focus of remembering the aim. We are losing sight of the aim, overall aim, both due to the single-mindedness toward the COVID-19 response, and also leaning or pushing the trainees to the acute problems or issues in the system, and thereby forgetting the quality improvement overall. Very strong statements, very strong views. We also think that in the style, they had a very great focus on the overall level, on the care provider level, on the patient level, and also backing those up with personal examples. So the style was very great. They could have been a bit more passionate about their views as to get those stronger through to the audience. So yeah, overall, great debate. Good job from Greta and Christina. And back to you, Helen.
Yeah, Christian, thank you so much. That was excellent, and well done, team, for the motion. So, Ellen, tell us about the team against the motion. What was the adjudication panel's view?
Yes, thank you, and thank you very much, everyone. It's very hard to decide, but the argument's so well done. But as Amar said, QI is not just alive, but it's flourishing, and it's about the process of improvement, learning by heart. Very passionate, and thank you. QI has always been successful when done, but under COVID-19, the barriers of QI was and is shutting down immediately. Very important argument, and something we see every day. No delays in hospitalization, use of data shared in a level never seen before across healthcare. COVID-19 shined the light on QI across the healthcare and community. And this is a cultural change we have never seen before, or barely seen before, and it is very much needed in healthcare and QI. And especially, again, across the healthcare system. So, QI is, during COVID-19, rather than being a project and mostly a day job for managers like me, being embedded in daily care where it belongs. So, to quote Amar and Bevan, improve the way we improve, it's very important, and adopt and abandon learning from COVID-19.
Yeah.
So thank you.
Yeah, Ellen, thank you so much. And again, I think the team the team against the motion, I think you should be really proud of your performance. As Ellen says, it was really strong as well. So, one thing that I really liked about the debate was we had patients, people that use services at the heart of it. So I'm really happy now that actually Tobias, who is a fantastic patient leader, is the chair of our adjudication panel, and is now going to tell us from the point of view of the adjudicators which team won and why. So I know that our debate teams are feeling very nervous about this. So Tobias, put them out of their misery. So tell us the conclusion that you came to and why.
We've been messaging back and forth and taking loads of note, and I think it's fair to say that from a patient perspective, quality improvement is more important than ever. But the question whether COVID-19 has killed quality improvement still stands. We've heard well thought out arguments, and as well as the speakers, they evoked powerful linguistic images. But in the end, what convinced us as adjudicators was the following arguments that the winning team used. We heard about the focus on safety rather than quality. We heard about the firefighting rather than improvement. We heard about the redeployment of QI personnel. But what really tipped the scale was actually Amar saying we should have used quality improvement. That helped us convince that Christina Krause and Grete McLaughlin, they convinced us that COVID-19 has actually killed quality improvement as we know it.
Okay.
But we need to revive it. We need it more than ever.
Yeah, brilliant. Thank you so much for your adjudication. It's been really fantastic working with the three of you. So, what we're going to do now is to massively thank our adjudication panel. We're going to get you to turn off your microphones and your cameras, and we're going to bring back our four debaters for the final vote. So, we heard there that we heard from our adjudication panel there, and Ellen, do you want to just pop your camera off? We heard there that the adjudication panel felt that the team for the motion had won the debate, but that's only one perspective. And what we want to do now is we want to hear a different one. So what we're going to do now is we are going to very shortly, when I give the word, we're going to show the result of the people's vote. So what we know is that at the vote at the beginning, okay, 21% of you agreed with the motion, okay, and 79% were against the motion. So so let's see where the votes have gone, and it's the team that has improved the most on its first score that will get the people's vote. So drum roll, which is my table. We'll see the votes. So let's see the people's choice. Let's see the vote now. Okay, so what we can see there is actually the most movement, okay, was on agreeing, because at the beginning only 21% of you agreed with the motion, but at the end 37% of you agreed with the motion. So congratulations to our winning team. But can I just say that both of you put up a really strong argument. And I did say right at the beginning to Amar and Bevan, you have got such a tough job, because everybody's going to disagree to start with, and it's going to be really hard to sustain that. And I just think you you all did so well. And just from the quality of comments that we can see in the chat box, what you did as a group of debaters is that you really made people think. And the kind of final thing I wanted to say was just the disclaimer, because actually what we asked you all to do was to argue a position, okay, hard. And the position that you argued wasn't necessarily what you think, but we asked you to argue, all of you to argue positions. And I think we should go back around, where is the dialogue going? Because whatever we think about COVID-19 and quality improvement, I think all of us who work in the continuous improvement, quality improvement field, we feel like now is our moment for quality improvement, more than it's ever been. So, let's absolutely move forward. So, can we all thank our 4 fantastic debaters for putting themselves up for having this virtual experience? So really well done to all 4 of you. That was magnificent. And can we also thank our 3 brilliant adjudicators? And finally, I just want to thank the people behind the scene. I want to thank Fiona, who helped with the questions, Kyle and Bevan Poddeep, who did a brilliant job, even though we had a few technical difficulties earlier on. So I hope that everybody enjoyed that debate and learned something. And wherever we are now, let's all keep moving forward, making quality improvement and continuous improvement the force that it can be to help us get the outcomes that we want for our people and our colleagues. And enjoy the rest of the forum. Have a great day, and goodbye from us all.